When penicillin first became available, it was hailed as a miracle drug, saving countless soldiers from the biggest wartime killer, infected wounds. 60 years later, many of the most potent antibiotics in the world are no match for drug-resistant pathogens, so-called superbugs, causing infections so virulent they can, and have, turned deadly within days. These lethal pathogens, resistant to some of the most powerful antibiotics on Earth, are a growing threat worldwide, particularly in healthcare, where patients are given an array of antibiotics, opening the door to new mutant bacteria with the ability to outlast our strongest antibiotics. It's a war between man and bacteria, and experts say the outcome is uncertain. We do know this: a growing number of studies prove healthcare professionals can successfully slow transmission and lower overall infection rates by these superbugs. In the next few minutes, we'll show you how. How does antibiotic resistance happen? When antibiotics are given, bacteria in the body have an opportunity to adapt. Some are killed by the drugs, but hardier bacteria survive by acquiring a resistant gene that allows it to avoid the killing action of that antibiotic. These mutant bacteria pass resistant genes onto their offspring, multiplying 1 million-fold in a single day, and increasing the potential for what some experts fear could be a medical Armageddon.
Come with me.
Antibiotic resistance isn't a new problem. Resistant strains emerged soon after the discovery of antibiotics. What is new, according to the Centers for Disease Control and Prevention, the CDC, is that virtually all bacteria in the world are developing resistance to the antibiotic treatment of choice. Let's look at 2 of the major organisms of concern in the battle against antibiotic resistance: methicillin-resistant Staphylococcus aureus, MRSA, and vancomycin-resistant Enterococci, VRE, and what you can do to stop the tide. MRSA is the most common superbug worldwide. Once a patient is infected with MRSA, there are only a few antibiotics powerful enough to treat it, and resistant strains continue to emerge. Found in hospitals and long-term care nursing facilities, particularly among patients with weakened immune systems, MRSA is resistant to methicillin, oxacillin, amoxicillin, and other penicillin-based drugs. Easily spread from patient to patient, experts fear we are losing the battle against this deceptive superbug. New data shows the number of MRSA-infected patients has tripled in the past decade, despite efforts to improve hygiene and enforce isolation precautions. MRSA enters the bloodstream through the smallest opening in the skin and causes deadly staph infections. MRSA is also a common bacteria found in surgical wound infections, urinary tract infections, bloodstream infections, and pneumonia. In hospitals, the most important reservoirs of MRSA are colonized patients, those who have the organism in or on the body, although it is not causing illness. Hospital personnel can also serve as reservoirs for MRSA, harboring the organism for many months, but typically they act as a link for transmission. The route of transmission is typically skin-to-skin contact and openings in the skin such as cuts or abrasions. However, MRSA has also been isolated in patient care items, such as stethoscopes and blood pressure cuffs, as well as environmental surfaces. Furniture, dry mops, and hydrotherapy tanks can also harbor MRSA. More alarming is community-acquired MRSA, a more virulent form of MRSA. Once found primarily in hospitals, it's on the rise in communities, affecting otherwise healthy people. Not only is it better at outwitting the immune response than more common Staph aureus strains that originate in hospitals and other healthcare settings, experts say it is able to combine resistance with virulence. Today, community-acquired MRSA is becoming widespread in contact sports, crowded living areas such as military barracks, prisons and homeless shelters, daycare centers, and among IV drug abusers and gay men. It is most common among children and young adults and individuals from racial minority groups. People with skin and soft tissue infections, such as a boil or abscess that is red, swollen, painful, and may have pus or other drainage. In many cases, lesions have been mistakenly diagnosed as spider bites that won't heal. But the bacteria can also show up as systemic, life-threatening infections, such as bloodstream infections or pneumonia. It is spread by close contact, either skin to skin with an infected individual, or by touching objects such as wound dressings, towels, razors, clothing, and/or sports equipment, contaminated with the bacteria without hand hygiene following this contact. Hospital and community-acquired MRSA strains are different, researchers say, but both types are increasing at an alarming rate. In fact, some physicians now treat patients for the possibility of MRSA by prescribing a more potent antibiotic, usually vancomycin, which has spurred new superbugs. VRE, found in hospitals and long-term nursing facilities, is the leading cause of healthcare-associated bacteremia, as well as surgical wound and urinary tract infections. These strains are resistant to vancomycin and many other antibiotics, and in some cases, all standard therapies. VRE can be transmitted to others by direct contact with stool, urine, or blood containing VRE. It can also be spread indirectly from contaminated hands of healthcare providers or from contact with contaminated environmental surfaces, including bed rails, wheelchairs, electronic, rectal, and ear probe thermometers, pulse oximeters, doorknobs, bed linens, and patient gowns. VRE is not usually spread through casual contact, such as touching or hugging, or through the air by coughing or sneezing. Visitors should wash their hands before leaving an infected person's room and wear disposable gloves if contact with body fluids is expected. Certain people are at increased risk of becoming infected with VRE, including patients with weakened immune systems and those previously treated with vancomycin and combinations of other antibiotics. Others at risk include hospitalized patients, particularly those on long-term antibiotic therapy and who have recently undergone surgical procedures, as well as patients with indwelling medical devices, such as urinary catheters or central intravenous catheters. While we can't win the war with antibiotics, experts agree that strictly enforced standard precautions and contact precautions, which include scrupulous hygiene, can reduce transmission of drug-resistant organisms and lower overall infection rates. Identifying MRSA colonized and infected patients at admission, particularly in high-risk settings, can reduce transmission to healthcare workers and patients significantly. At minimum, high-risk patients, roommates of patients newly infected, and patients admitted to high-risk areas should be screened on admission and intermittently thereafter. Stool cultures or rectal swab cultures should be taken to determine the presence of VRE. If MRSA is suspected, a laboratory culture should be obtained from the infection site. If Staph aureus is isolated, the organism is tested in the lab to determine which antibiotics will be effective for treating the infection. Until the surveillance culture is known to be negative, patients should be put on isolation precautions whenever possible. Once infected and/or colonized patients are identified, patient charts should be flagged immediately to alert caregivers of new infection colonization status and isolation requirements. If the patient is readmitted to your facility, the chart should indicate prior colonization or infection status. Standard precautions must be used for all patient care, including strict adherence to hand hygiene and barrier controls for colonized and/or infected patients. Hand hygiene is the single most important means of preventing the spread of both MRSA and VRE. Wash hands after touching blood, body fluids, secretions, excretions, and contaminated items. After removing gloves, wash hands immediately. Wash between patient contacts to avoid transferring microorganisms to patients and the environment. Also, wash hands between same patient procedures to prevent cross-contamination of different body sites. When hands are not visibly soiled, use alcohol-based hand rubs before and after each patient. Alcohol-based hand rubs reduce the number of microorganisms on skin significantly and cause far less skin irritation than soap and water. And according to the CDC, they take less time, saving an estimated 1 hour of an ICU nurse's time per shift. Product should be applied according to the manufacturer's instructions. Wear appropriate personal protective equipment when contacting blood, body fluids, secretions, excretions, and contaminated items. If a splash is possible, protective eyewear is required. Studies show glove use reduces hand contamination by 70% to 80%, prevents cross-contamination, and protects patients and healthcare personnel from infection. Clean gloves must be donned before touching mucous membranes and non-intact skin. Remove gloves between patients and before touching non-contaminated equipment and environmental surfaces. Decontaminate hands immediately to avoid transfer of microorganisms to other patients and/or environments. Masks, eye protection, and/or face shields must be worn during procedures that could generate sprays or splashes of blood, body fluids, and excretions. While masks are not routinely recommended, many healthcare professionals choose to use masks with all infected and colonized patients to protect themselves, co-workers, and other patients from contamination. Environmental surfaces such as countertops, bed rails, charts, and patient equipment can be contaminated with VRE and/or MRSA, and the organisms may survive for weeks to several months on various surfaces. Handle patient care equipment soiled with blood, body fluids, secretions, and excretions carefully to prevent exposure to skin, mucous membranes, clothing, and to avoid transfer of microorganisms. Reusable equipment must be sterilized between patients and single-use items properly discarded. Linen soiled with blood, body fluids, secretions, and excretions should be handled, transported, and processed carefully to prevent skin and mucous membrane exposures, contamination of clothing, and transfer of microorganisms to patients and environmental surfaces. Strict adherence to contact precautions must be followed in both hospital and non-hospital settings. MRSA-infected patients should be placed in a private room, or if not available, the patient may be cohorted, placed in a room with a patient who has active MRSA infection but no other type of infection. Or place infected patients with a patient who does not have risk factors for infection. Caregivers should also be cohorted. Clean, sterile gloves must be worn when entering the patient room and changed during patient care after contact with infectious material that may contain high concentrations of microorganisms, such as fecal material and/or wound drainage. In one study, 42% of nurses' gloves became contaminated with MRSA when they touched surfaces in the room of a patient with MRSA without actually touching the patient. Gloves must be removed before leaving the room and hands decontaminated immediately with an antimicrobial agent. After glove removal and decontamination, hands must not touch potentially contaminated environmental surfaces and/or equipment in the patient room. Gowns must be worn if your clothing will have substantial contact with the patient, environmental surfaces, items in the patient's room, or if the patient is incontinent, has diarrhea, or an ileostomy or colostomy, or wound drainage not contained by a dressing. Gowns are removed before leaving the patient room. After removal, keep your clothing from touching potentially contaminated environmental surfaces and equipment to avoid transfer of microorganisms to other patients and environments. Limit patient transport to essential purposes only. If transport is necessary, follow strict precautions to minimize the risk of transmission of microorganisms to other patients, environmental surfaces, and equipment. Limit non-critical patient care equipment and items such as electronic thermometers, stethoscopes, blood pressure cuffs, and bedside commodes to a single patient whenever possible, or cohort items with patients infected or colonized with MRSA. Patient care items, bedside equipment, and environmental surfaces must be cleaned daily with a facility-approved disinfectant. Since healthy people are at low risk of infection with hospital-acquired MRSA and VRE, casual contact, such as kissing, hugging, and touching, is acceptable. Visitors, including children, are allowed, but they must follow isolation policies of the facility. In non-hospital settings, patients should be allowed to socialize. Infected or colonized patients can participate in group meals and activities if draining wounds are covered and body fluids contained. Ensure that the patient observes good hygienic practices. A policy should be in place for when patients can be removed from isolation. According to the CDC, patients with VRE should have VRE negative results on at least 3 consecutive occasions, 1 or more weeks apart. CDC recommends that local health departments be consulted regarding discharge requirements for patients with MRSA or VRE. In the last few years, Clostridium difficile, C. diff, is an emerging concern. A new strain developed that is resistant to usual antibiotic treatment, and studies are underway to better define the problem. Practical ways to prevent C. diff from spreading are listed and continually updated by CDC. Scientists are hard at work developing new antibiotics, but with no magic bullet drugs on the horizon, healthcare providers must take measures to slow antibiotic resistance. Cautious stewardship of antibiotics is key. Antibiotics must be restricted to patients who can benefit, those with bacterial infections, and patients educated on the importance of taking the full round of antibiotics. If drugs are stopped too soon, resistant microbes proliferate. When the infection returns, a different drug must then be used to treat it, often more expensive and more toxic. Healthcare workers can stop the spread with simple approaches that work. Studies show that strict adherence to barrier precautions, hand hygiene, and prompt identification and isolation of infected patients can slow transmission, lower infection rates, and save countless lives.